control his shortness of breath despite his aggressive disease management. There was a plan in place to support his wife. And that's a very active home health aid program and volunteer program. And that was just a load off of them because what they wanted most could be achieved by this.
So I'll pick up because he was discharged to my care. And you know, one thing that Ursula's words brought to mind that I think it's worthwhile sort of pointing out. Higher? Okay, thank you. Besides that I need to move the mic closer to my mouth. Is that, you know, a lot of people go to the emergency room not because they want to be put on machines and want everything done to keep them alive forever. Most people go to the emergency room because they need help. And, you know, we unfortunately don't do a lot of talking to people about, gee, what are you here for? You know, and I will say this is getting better. In fact, at Fletcher Allen, the ER docs are some of the most sensitive to palliative care issues in the hospital, because they do have people coming in at the end of life where they really know there's not a lot that can be done from a disease, from a life lengthening standpoint, and they're often, you know, it's really, they see the saddest moments sometimes. So, but you know, for somebody like this though, who has repeatedly felt bad and gone to the hospital and felt better, and felt bad and gone back to the hospital and felt better, even though each time he was getting weaker, you can imagine that if the only thing in your past that made you feel better is go to the ER, it's sometimes hard to help them understand there might be something different. And a big part of changing somebody's frame of mind in this way is demonstrating trustworthiness and availability. And I give a lecture to the medical students where I present a case of heart failure and I say, you know, I go through the presentation, you know, somebody I've seen at home with heart failure, and then I say, what's the most important clinical skill in taking care of this patient? And the hands go up and they, you know, they tell me various aspects of the drug management or the physical diagnosis. And then I say, no, it's showing up. Because if you don't see the patient when they have the start of their symptoms, you can't intervene and make things better so that they don't get worse and go to the emergency room. And that was really this gentleman's issue, is that he would start to feel bad and it would just escalate. They would have trouble getting the help they needed, and so he would end up in the ER. So I started seeing him at home, and he was very reticent to start on morphine. We have a whole bunch of drugs to help the heart function as best it can, and we add one, and we add another one, and we add another one, and then you kind of get to a place where there's really not many more options. But there's a drug called morphine, which has two effects. One is that it is what's called a vasodilator. It dilates the blood vessels, making it easier for the heart to do its work. So if you go into an ER with severe congestive heart failure, the first thing they will do is give you some IV Lasix, which is a diuretic to get the excess fluid off, and IV morphine, which will dilate those veins and make you feel better within 20 minutes. Okay? But most people think morphine and they say, oh my gosh, I'm dying. Or they have either experienced or seen someone else get a dose of morphine that was too high and made them totally out of their mind. And so they say, oh, I don't want that drug. Well, I had a time of it convincing this guy to try some morphine. And I think I really did start with literally like a half a milligram, which, you know, frankly is kind of a whiff from the bottle, you know. And, but, you know, the trustworthiness had to be there before he was really going to go along with the plan. So, you know, I started at extremely low dose. And I just remember vividly sitting at their dining room table, and his wife had the little, you know, the meds there in the corner on a table, and you know, each time going into what he was actually taking and how it was going, and turning to him, and he would always be very surprised that he was taking morphine and was still awake to talk to me, you know, and of course he was perfectly fine. And so it's just, I really want everybody to know that, first of all, everybody's response to morphine is different, and if you've never seen morphine or any other strong pain medication before, the first dose has to be a very, very light, low dose. And that is a fact that very few healthcare professionals get. So if you think you're in a setting where, gee, people really should know what they're doing, it's a little frightening. I asked the physician caring for my father, who was dying, I said, you know, my mom knows it's the end. She wants to stop the oxygen, but I'm wondering if you are comfortable with the use of morphine to relieve shortness of breath. And he started screaming at me over the phone 3,000 miles away saying, "I will not kill your father, I will not kill your father." Fortunately, my dad exited stage left before it got too much worse. Anyway, you know, there's so much misunderstanding among both the general public and physicians out there, and all healthcare professionals. And so it's really, I just want to empower each one of you to know that there's a low dose of medication that will take care of symptoms, whether it's pain or shortness of breath or both. And in fact, when you have when I've had patients who have both shortness of breath and pain, like with lung cancer, as you start low and you start working up the dose, you tend to get control of the shortness of breath before you get control of the pain. It's easier to control, you know, lower doses of medication control shortness of breath than typically control pain. So convinced this gentleman, titrated his dose very slowly. He stayed thoroughly coherent and really completely himself. Let's see where we are here. So in this gentleman's care, the role of palliative care for him was very attentive medical management, meaning that we watched his heart failure very closely through physical examination. He was in a wheelchair, and so and without use of his legs, so weighing him was difficult. But most people with heart failure, I'd be weighing on a regular basis, having them call me when their weight goes up, because the first thing that happens when your heart tells your kidneys things aren't going so well, could they please suck up some more sodium and fluid? And so people's weight starts going up. So that's what we do. But we also talked a lot about goal clarification. Once he knew that help was available at home, he was very happy to give up the idea of going to the hospital, especially because the drugs he had at home, which were the Lasix and the morphine, were the same drugs that they gave him in the emergency room. So he got that. And then we started talking about the future. And again, building trust, helping people understand that there's a system there to help them, having the hospice team come in, and in fact, he stabilized. So he graduated from hospice, which is not unusual at all for somebody with heart failure. In fact, I had a gentleman a few years ago that I took care of with heart failure who I started on morphine, very afraid of morphine, stabilized, went off hospice, got worse 6 or 8 months later, went back on hospice, upped his morphine a little, he stabilized again. About that time he says to me, "I think this morphine's keeping me alive." I said, "Yes, I think it is." And interestingly, he died on his 3rd bout on hospice a number of months later, but it wasn't of heart disease. It was actually, he caught a really bad respiratory infection, which the rest of his family kind of blew off pretty quickly, but he had a rough time because he was so debilitated from his heart disease, and that was his 3rd hospice admission. So helping people think about in the future what's going to happen. It's very frightening to think about a crisis right today, but if you have time to think about in the future, thank you. If you have time to think about in the future what might be happening and how we're going to take care of it and what options you'll have at that time, most people feel much more comfortable with those kinds of decisions. I just think it's much easier to make those decisions ahead. So now, back to Ursula.
I'm going to add another story about the use of morphine for pain or for shortness of breath, and just along the vein of how to advocate for yourself or for loved ones, is that people worry about morphine, and even physicians, because overdoses of morphine can suppress people's breathing. But we don't overdose people with morphine. And it is not a difficult drug, but it is a drug that most professionals are not always comfortable titrating, starting low and finding the lowest effective dose. But if you ever get the sense that your provider doesn't feel like it's safe to use morphine, or if they're asking you that you have to sacrifice your desire to live longer to be more comfortable, then you should ask to have somebody who's more comfortable with titrating morphine. So, because I don't ask people to accept that morphine might shorten their life, because I know well before I'm anywhere near the range of morphine that could cause somebody's life to end. And that's another myth about morphine that's unfortunate, but it's good to be careful. So this woman, this is our last case, is a woman I cared for last year, and she lived up in the St. Albans area. She was in her 80s, and she had advanced kidney disease. And she had been living with kidney disease for years. And a year ago, her kidney function was at the point where they recommend starting dialysis. And her kidney doctor and her sat down at that time, and she wasn't having symptoms from the kidney failure, and she did not want to go on dialysis. She knew about dialysis for her because 5 years earlier, she had been in the hospital with an acute, serious illness in the ICU. That illness had hurt her kidneys, and she needed dialysis for a few weeks following that. So she had had an idea about what it's like for hemodialysis. And it's a process where you go into a clinic or a hospital and are connected to a machine through a line that's connected to your blood vessels. And this machine takes a large volume of your blood out of your body and filters it and does the work of the kidneys, and it returns the blood into your body. And people sit in a dialysis unit for a few hours, 3 times a week. And not uncommonly, people might be tired afterwards. But for people living with kidney failure, it can really help them live well and live longer to have this procedure done. What's tricky is in the population over 80, it's hard to know if kidney dialysis is actually helpful. And when they look at patients who decide to get dialysis and don't decide for or against dialysis, that the population in general lives as long whichever they decide. But what's hard is for an individual, it's hard to know, would your life be longer if you started dialysis today, or would your life be longer if you didn't? It's a very difficult decision. The other part about dialysis that's tricky for people over 80, and it really starts at age 70, is that dialysis can take a lot out of somebody, and it can cause that people get weaker in the year following dialysis. And so it can be part of a frailty syndrome. So some people feel like, well, I'm feeling crummy, I'll try dialysis, but it doesn't get them stronger when you're in a frail state to begin with. And so because she'd had the experience with dialysis, and a year ago, learning that she was meeting the criteria to start dialysis, she decided not to do it. And she said she would never do dialysis again. And that was her mantra. She was going to live her life until her life came to an end, and she would never do dialysis. And she lived a year. And her nephrologist, her kidney specialist, told her, you probably would have had a shorter life if you had done dialysis. But now a year in, she's starting to have some difficult complications. And for her, it was the kidneys not being able to get rid of fluid. So she was building up fluid in her body, and then her heart was failing, and she was getting fluid in her lungs. And so she was admitted to the hospital 3 times within a 3-week period for building up this fluid. And as soon as she got home, she wasn't able to keep the fluid off. And the IV medicines worked better than the oral medicines is one reason why, but it was getting very discouraging that she was only home for 3 days before she was back in the hospital. And she was at this crossroads where she said, I don't want to die, and I don't want to do dialysis, and I don't know what to do. And her nephrologist had her transferred her care from St. Albans down to Fletcher Allen to figure out how we could better manage her fluid, but also to have a conversation. And he asked me to meet with her to help her think through this treatment decision and to help her think about what would it look like if you went and pursued dialysis, and what would it look like if we managed your symptoms without dialysis. And so I sat down and met with her and her family, and I learned that over the last few weeks, she is now living full-time with her children, and her son-in-law was her primary caregiver. And their intent was they would care for her until her life came to an end, and they loved her dearly. She had 3 daughters, and she had numerous grandchildren. And when we sat down to talk, and I said, can you tell me about what this has been like for you? She just was at this point of, I just don't know what to do. And she said, I don't want to die, and I don't want to do dialysis. And I said, can you tell me more about that? And she said, I love my grandkids. I just can't choose to die. And I sat back and I asked her, do you feel like you're deciding whether or not you live or die? She nodded. And then this is the sensitive bad news part, was that her life was coming to an end no matter what she decided. And I felt like the burden that she had was that she was saying, my life isn't worth living, but I don't want to do this other road. And I said that it doesn't matter what you decide now. Your life is coming to an end from this illness, and all you have control over is not that your life is ending, but what you do between now and then. And she said, well, I don't want to do dialysis. And then that was the last time we talked about dialysis. And her family, they were so lovely because they were saying, Mom, whatever you want to do, we can support you, whatever you want to do. And then we talked about, well, how can we do aggressive fluid management at home? And how can we help you be at home? And how can we help your shortness of breath if you get into trouble at home? And how can we help you so when you're at the end of your life that you die peacefully and in a way that you want, which was her family really wanted to care for her at home. And we worked with the heart failure team on this aggressive fluid management program. And we were even instituting with the hospice team using subcutaneous Lasix, which is a fluid diuretic pill, because the oral pills weren't working for her. And we put in place a very aggressive plan of monitoring her weight and being very aggressive to keep the fluid off for as long as possible. And what started happening over the next couple days is she started to get weaker and sleepier. And it was apparent that she wasn't going to have a lot of time. And her family never questioned, should we do dialysis? And she was having this wonderful moment of getting her affairs in order, but saying the things to her family that she wanted to say. And it was just a very touching time. And she did get home, and she enrolled in this hospice program and talked to her primary care doctor, and we had a very aggressive plan to help her live as long as possible and to help her transition to the end of her life. And I asked her son-in-law, how long could he do this? And he said, as long as I have to. And they did it. And so her goals were to not suffer. She wanted to focus on quality of life. She didn't want to be, to go through burden, and she wanted to be at home. I think one of the things I do a lot in the hospital is I help people think through, what would it look like if you chose this? And what would it look like if you chose that? So we sort of get to the heart of what's the decision that has to be made? What's important to you? And help you think about it. And I would say that, and being an internist before I did palliative care, that if you were to record the conversations in the hospital, that 99.9% of our conversations with patients are about giving medical information and talking about how we're managing their disease. And one of the things I noticed is that we might say things like, if you don't want to, for example, if you don't want to be on a ventilator, we could just keep you comfortable, but not really describe what that would be like or what that's like. So sometimes I spend quite a lot of time just saying, well, let's talk about it. When they ask you about being on a ventilator and you're worried that it would be that your life would come to an end on a machine, well, let's talk about what would it look like if you didn't want to be on a ventilator at the end of your life? How would we care for you? What would your care look like? And a lot of this, too, is describing that we're still doing medical care. We're still going to be thinking about anything we can that can be helpful. But we have lines that we draw about things that are burdensome, that either they don't want to be done because they're too burdensome, or they're burdensome and not going to get somebody where they want to go. It's not going to achieve their goal. And so that's the what if. And I'll come in and ask, are you interested to know what your care would look like if you wanted to have aggressive management of your symptoms at home such that you didn't have to come back to the hospital? Or you're interested to know what it would look like if you were having trouble breathing and we were to do aggressive symptom management and had a plan in place that if you were critically ill, to not be in the intensive care unit at the end of your life. I mean, for people to say that they're not going to do something, you need to know what you are going to do. And that's the focus of these discussions. And so there's these transition points of, this is what this road will look like, and this is what this road will look like. And sometimes it's the contrast of, this is what aggressive disease-directed care is, or this is what it would look like to do aggressive or burdensome treatments. And that's sort of our lingo for ICU level care, like being on a ventilator and having a lot of intensive or aggressive things that are done to the body with the intent of getting better. And for many people, it can achieve that goal. But what if we looked at quality of life, or being comfortable was the priority? What would your care look like then? To help people make informed choices. And then the other thing that happens is that we have people make these choices, and it can feel like they're deciding between living longer or living well, quality of life or longevity. And sometimes the choice might impact how long somebody lives, but there's a lot in between. And we can do a lot for quality of life while we're still doing aggressive care or with intent of living as long as possible. And the other thing that's tricky is that sometimes it doesn't matter what you choose, that the end is going to be the same. And having a doctor that can help somebody see that so there's not a burden, whether it's on the patient or a family member, to feel like they're making a decision that might end somebody's life, is to take that burden off that someone's life's ending no matter what you decide, and you're just deciding what you want to do between now and then. And I would say for surrogate decision making and for family members, just being the person to say that is an incredible burden that's lifted. Because there's a lot that we're not at the end of life, deciding whether or not we do live or die. And the other thing to know is that this road may not be shorter, and this road may even be longer. And there are some illnesses and there's some times where we're not sure. The doctor can't say, this is the road to the longest life. And in those situations, I think a lot about, well, what do you want to be doing? And let's make sure we're doing that. Whether or not you do aggressive care or aggressive symptom-directed care. So that's the navigating the roads. So for Mrs. S, I think it was more, this was the road that she was deciding between dialysis or comfort-directed care. And her nephrologist wasn't recommending dialysis. He did not think it was going to go well. He didn't think it was necessarily going to prolong her life. And so just alleviating that burden that she wasn't deciding whether or not she lived or died. She wasn't saying that she was wanting to leave her family. She just really wanted to be comfortable and not undergo burden. And I think she knew her body couldn't handle it. It would have just been too much. She's a very nice woman.
And in talking about this case, we started to think about, how could this woman's health life maybe have been different if she encountered palliative care in the community before she went to the hospital, as opposed to having been in the hospital. And especially for somebody who'd been in renal failure for a year, this is a real opportunity to talk to people about what might be coming down the pike. Many times, we as doctors, we know what's going to happen to somebody pretty close, like within a couple of, a narrow range. We don't know when it's going to happen frequently. I mean, I couldn't tell anybody exactly when, but we have an idea of what people are going to face in the future. And that's something that, as a patient, you can let your doctor know that you really want to hear about that. Because it is useful, as I say, to make decisions ahead of time, to have time to think things through in a non-panicked way. But especially when, I for many years thought of especially the hospital as sort of a conveyor belt. You jump on and you have to go where the conveyor belt takes you. And maybe you don't want to go there. Well, you got to figure out what to do instead of jumping on the conveyor belt, because if you need help and the hospital is the only source of help, you might end up on a conveyor belt you don't want to be. And I don't mean to, I'm not trashing the hospital. I mean, the hospital is really great if you want and need what it can accomplish for you. But if you might have different ideas, it's really good to have a plan. And so this is a really big argument for thinking about palliative care earlier on in a person's trajectory. So I had a patient similar to this lady in that we knew eventually her kidneys would fail. This happened to be a woman with cancer where her bladder was taken out, and the surgeon called me from the operating room and said, I know there's still cancer left in there on the ureters, which are the tubes between the kidneys and the bladder. And he said, but she'll have a lot of time, given what I took out, she'll have a lot of time. And so we talked about the fact that, eventually this cancer would come back and would probably lead to kidney failure. And so what I was doing was watching, I draw her blood periodically, and we'd look at the measure of kidney function. And I was really dreading the day I was going to her house with the news that her kidney function was starting to deteriorate, because that meant the cancer was growing. And part of me, she actually had already had one of her kidneys sort of taken out of action. So that meant that this was really this was sort of a pretty big point. And a bizarre, just part of anatomy is that when you have cancer below the waist, it has to do a lot of damage before it kills you. If it doesn't block off your ureters, that's the only mechanism of death down there, okay? As opposed to if you've got a tumor in your chest where your heart and your lungs are, two very vital organs, the cancer doesn't get too bad before it kills you. And I know this is a really warped perspective of someone who's been doing this for 20 years, but you know, the damage that a tumor in the pelvic area can do to somebody while they're still alive is pretty horrific sometimes. So, you know, I really like this lady, as I like a lot of most of my patients, and I was really dreading her, because when cancer starts to block a ureter, you can fix that by just putting an alternative pathway. You put a little straw in and keep the kidney going. Meanwhile, the cancer goes on to destroy more of the body and the tissue. So I was really dreading, because I kind of knew what I wanted her to do, but I'm not supposed to do that. I'm supposed to give people, you know, all the information and let them choose. And I went to see her, and I was so surprised by our conversation, and it was just such a reminder that, you know, I learn every day in this work, because every person is different. And so I described, you know, what was happening to her and what the situation was, and at, you know, my totally lame attempt at a little bit of humor, which is really out of my own discomfort, I said, but of course death from kidney failures actually can be very comfortable. I personally want to have spigots on my ureter, so if anytime anything gets too bad, I can just turn off my spigots and go into renal failure and exit. And she stopped. I know it was really a lame attempt at humor, it really was. And she stopped and she said, "You mean I could control the timing of my death?" And I stopped and I thought, and I really never thought about it before, but that's kind of really what it was. I said, well, yeah. And she said, well, that is just so great. I said, really? Well, we talked more, and I'd been taking care of her for a number of years at that point, but right before I had met her, her husband had died of cancer as well, and he had deteriorated very, very slowly over a long period of time. And when he was dying, it wasn't really clear that he was as close to the end as he was. And they had 6 kids spread out across the country. And when it became clear that he was dying, she called all the kids, but 2 of them didn't make it home in time. And she said to me, she said, you know, it didn't matter to him and it didn't matter to me, but it mattered to them. And she said, what I want more than anything is for my kids to get here, to be here when I go, because I know how important it was to them when this happened to their father. So everybody had tickets to come visit her for her birthday.